Thanks very much. Well, as I said earlier today, VMIA are very supportive of this project, and Ursula Harrisson is going to speak to us today about sustainability and towards better healthcare. And as those of you know who've been in the space for some time, VMA have been a very important partner in things like the fetal scalpel FSC program, education program, and another project they're also involved at the moment, which is called our dashboard program. So welcome, Ursula. Thank you.
Right, thank you, Christine, for the introduction. So today I'm going. Oh, sorry, that's going wrong way. Oh, I've lost my title slide, but never mind. It doesn't matter. I'm going to actually talk to you today about towards sustainability, which is investing in patient safety, which is one of the key things that we do at the VMIA. We're not just an insurer. We actually invest a lot of money into patient safety initiatives because at the end of the day, they help to reduce harm to the Victorian community and therefore also reduce the claims as well that are the dollars. So the VMIA's purpose is to build a confident, resilient Victoria through world-leading harm prevention and recovery. And harm prevention really is around all the investment that we do in patient safety initiatives and also the risk advice that we provide health services and other government departments and other agencies. But we also work in harm recovery, and that's really around our insurance and claims. And that's actually helping services to recover when they've had major losses. And therefore, that's one of the key purposes of what we do at the VMIA. Sorry, I'm going the wrong direction. So we have more than 4,300 clients that we have, and we have over $188 billion worth of insured assets. We are a state captive insurer. We work under an act, and we are an agency of the Department of Treasury and Finance. We provide a lot of risk advice, and we underwrite and develop insurance products specifically for the Victorian government. Some of those clients that we actually look after include the 7 government departments, rural health centres and hospitals, including bush nursing, that's around 280 clients, rural GPs, and community service organisations, which are around 2,300. So we service a lot of clients. And in fact, some of the public buildings that you see around Melbourne, we also insure those as well, including the Arts Centre and so those are some of the places, and Flinders Street Station. As you know, the public health sector, we do... I've lost my train of thought. So this is just a quick snapshot of the public health sector as we know it. We have around sort of 6 million people living in Victoria, and of that we have 149 public acute hospitals, and we do around 57,000 public hospital births a year. And when we think about the fact that we insure you and we pay out your claims, the claims accounts for around 250 medical indemnity claims annually. And that comes from around 3,000 to 4,000 notifications that come from health services. So what is actually the problem? Well, the problem is very simple. We know that patients, when they come into hospital, about 1 in 10, and that's figures from the WHO, will suffer some patient harm, whether that's avoidable or unavoidable. And we know around 50% of those 1 in 10 will be avoidable harm. So the problem is actually quite huge. However, when it comes to claims, really it's around what is actually, what we can actually, defend you, and also what kind of harm the patient has been submitted to in hospital. But we do know that patient harm can cause significant pain and suffering to patients and families. And additional to this, it also has financial consequences. So this is actually data from the United States of America, and this was actually from a recent BMJ article. They actually looked at the causes of death in the States, and they found of the 2 million odd cases that around 251,000 were actually attributed to medical error, which showed that actually it's the third... Sorry? Oh, sorry. So I thought there was somebody asking a question as I was doing the presentation. They found that actually a third of all deaths were attributed to medical error. And what they actually found was it was very difficult to actually understand that data, purely because the actual causes of death are not attributed to medical error. There's other reasons why they put other reasons as to why that patient has died. So we know that we do lots of different types of claim, including building insurance, PPL and employment insurance, but we also, we found that around 63% of all our 63% of all the claims that we get come from medical indemnity, which is actually quite a large part of our liability. And of that, when we actually look at the 10 years of incurred costs, and that's 10 years from 2006 to 2016, around 201 million comes from obstetrics. And actually obstetrics is our biggest area of medical indemnity claims, followed by emergency medicine. That usually accounts around about a third of our costs. And that's not just volumes, but it's also the cost of claims as well. Obstetric claims actually are quite expensive. They're on average, around 4 million for some of the bigger losses. Excuse me, I've got my notes. We also know that we've had a number of healthcare examples of where major harm has happened in healthcare, whether that's globally and here in Victoria with Bacchus Marsh. And we had also Morecambe Bay in the UK in maternity. And recently we had James Titcombe come to Victoria to talk about his experiences at Morecambe Bay, very similar set of circumstances. And the way the VMIA really actually supports, this is really part of some of the work the VMIA does in the recovery space, in actually helping hospitals recover from such disasters. And basically, we do know that medical indemnity cases have a strong emotional component and deep impact on the community. And this was very much the case of what happened at Jiawara Health. And our role in these cases is not just simply to manage claims and pay out the agreed settlement. In this particular case, we actually assisted the hospital around managing things like open disclosure processes with families, given the fact that of the actual individual cases. But we also worked a lot with the hospital's governance team to implement new processes and oversight and to train their senior leaders in risk management. And from that, we've been able to also, as a state risk manager, I suppose, provide some larger scale opportunities in which those particular errors can be discussed in an open environment, but also in a protective environment, and where actually lessons can actually be learned from these cases. So as you know, following the Bacchus Marsh, there was the Duckett report, which was known towards targeting zero, which is supporting the Victorian hospital system to eliminate avoidable harm and strengthen quality of care. And I agree, it was actually a very important report. It led to the introduction of the new agencies that now can support health services better when it comes to safety and quality, which is Safer Care Victoria, but also around data and insights, which is the VAHI, which is the Victorian, I think, Health Information Agency. But the VMIA, as part of this, really feel that they're very committed to patient safety, and it's always been one of our key commitments. Because we do believe that actually investing in patient safety is very important in order to bring down, obviously, medical indemnity claims, but also reducing harm to the Victorian community. And as we all know, with the Duckett report, we supported the findings, which was obviously around prioritising safety and quality, rigorous approach to improvement, meaningful measurement, culture of candour, and patient-centred hospital system, which we can all agree is very important. So one of the questions that Felicity asked me was, what are the main things that come out of our medical indemnity claims when it comes to obstetric medicine? And we did actually commission a report around about 3 years ago where we actually did an audit looking at some of our medical indemnity claims that were in obstetric. And what we found was really around sort of errors around admissions of patients where things might have been missed. Obviously CTG monitoring, whether that's CTG monitoring or intermittent auscultation, when should it happen, recognition of, the deteriorating fetus. But one of the key things is communication. That's communication including handover of care and actually how teams actually work together. The other thing as well was around syntocinon, and I think it was very refreshing to hear that in the induction of labour guidelines, syntocinon has been addressed. Because it actually does lead to, can lead to, if given to higher concentrations, to issues with CTG monitoring. But also it's around policies and procedures and actually following those appropriately. And also having the right policies and procedures that are actually evidence-based. And one of the key ones is documentation. And as I always say to anybody, if you don't write it down, it never happened. And I think for us, in terms of the VMIA as being, your defence, we like to, we can defend you if it's actually written down, but we can't if it hasn't been written down. So it's just a little something to take away with you. But I always believe that prevention is better than cure. And we have lots of things that the VMIA has actually invested in to look at how we can actually prevent these harmful events happening in healthcare and reduce possibly errors. And there's lots of areas that we have actually invested money in, which obviously one of those would be human factors. And I'm sure you heard of the Human Factors Forum that was about a month or so ago, but also other safety initiatives, some of which I'm going to go through with you now, just to give you an illustration of how those can actually have an impact on claims. Education and training, we know that the VMIA was key in the development of FSEPS, which is a fetal surveillance program, but we've also invested money in PROMPT, which is the practical obstetric multi-professional training, and we also support MSEPS as well with the Department of Health. But just to go back to PROMPT and the work that we've done around PROMPT and FSEPS, this is really illustrating the number of hospitals that came into PROMPT in 2010 and now the hospitals that are currently running PROMPT. But what you can see from this graph, when we introduced fetal surveillance, what we found is that the actual number of claims, and that's exposure adjusted, started to actually come down. And that's because obviously that's training around CTG monitoring, and probably people, obviously with that training, people are recognising when the fetus is becoming compromised. But then that sort of began to sort of plateau a bit. And so when we introduced PROMPT in 2010, we've had a further reduction in medical indemnity claims. And that's possibly because PROMPT is an evidence-based training program. It's a course in a box, which basically has got quite firm data around how it can reduce things like shoulder brachial plexus injury and hypoxic encephalopathy. But what it does do is it actually focuses a lot on teamwork and actually on team building and communication and situational awareness, all those things that were, that really help a team work together. But additionally to that, it was actually a course recommended by CMACE in 2009, which is the Confidential Inquiry to Maternal Deaths, because they actually found that some of the deaths that were attributed to mothers in the UK were avoidable if people actually worked and communicated together effectively. So as we can see from our claims information, we can see that actually has got an effect. But it's not negating other training programs, and it's not negating other risk management, maternity risk management products as well that are happening in hospitals. So it's just two illustrations. So guidelines and protocols. Well, obviously the maternity ehandbook is the guidance that we're all looking at, and I think it's very important to have a consolidation of guidance and of guidance, particularly, especially evidence-based practice, because that really then feeds into better care for patients. And I was very keen to get involved in this particular project because I think it actually has got a lot of weight, purely because it is around evidence-based practice, and it's very important that people are practicing as consistently as possible. But we actually have other programs that we have been involved in as well in the maternity space. One of them being the dashboard, which is the maternity indicators dashboard that will be coming very soon to a hospital near you. We're in the pilot stage at the moment. We also funded the M&M committees as well, which were done regionally, and I think there's additional funding to continue it until next year. Which actually has got a lot of weight. And I think in the end, it's really closing that loop. We've got the training, we've got the M&M committee, so there's the learnings when things don't go right. We've got the policies and procedures that can then, see whether those things are actually working, and that whole plan, do, act cycle that we've just had from Craig. It's really consolidating that together into one wider strategy to try and reduce harm to the Victorian community, particularly to mothers and babies. And this is really to illustrate some of the work that the VMIA have put their weight behind. Obviously, we have the maternity indicators, which will be rolled out very soon. Prompt is and we actually decided to call this a bit more a maternity education program in some ways. And the Maternity ehandbook, which is at the centre. We value its contribution, and the mortality and morbidities committees. And we're actually thinking, what is the next step, really? We've done all this work in risk mitigation in maternity. How can we actually incentivise safety? And that's the next step. I can't tell you much about that at the moment, but we are looking at ways in which we can incentivise hospitals to do these things so that they can reduce the risk and also mitigate harm to mothers and babies. Because at the end of the day, we feel that these investments actually are worth it. Just to give you an idea that though we're doing all this work, people are actually looking at us, not just from an Australian perspective. We get quite a lot of approaches from the medical defence unions, but from other insurance organisations, and not just ones in Australia, but ones that are outside Australia, like in Europe. We have actually started working very closely with European insurers to show them the good work that we have done in Victoria around particularly maternity, because that's always at the top of people's list. But really to sort of share the information and some of the ways that we have done this so that they can take it home with them and possibly trial it in their own countries. So it's really trying to build a relationship to improve sustainability in reducing patient harm and harm to mother and babies, particularly because maternity is one of those areas of focus. But also we have put some investment into evidence, or we'll call innovation and research. And we have got a partner at the moment that we're working with, and we're thinking about the next bit of the equation. And the next part of that equation really is going to be looking at patient-centred care, because that's very important. It's part of what Duckett has, in targeting zero, but also governance and how we can strengthen the governance of hospitals and health services. And the last bit is misdiagnosis, because even though we've done all this work in maternity, we're still seeing medical indemnity claims attributed to errors in diagnosis, misdiagnosis. So we're actually putting some investment in that as well. And I'm nearly at the end. So these are some of the other things that we can offer, because there might be some administrators but also for clinicians as well. We do provide a range of services, not just prevention, but we do a lot of risk advice. We do a lot of client training programs. So I would really urge you to go and actually have a look at our website. We do run workshops and forums, and we support workshops and forums for other agencies as well. And we also have a number of toolkits and resources. So we are going to be giving out some packs at the end, which have that sort of information, which you can hand to your administrators, or you might want to keep it for your own information. And that's all. Thank you very much.
Ursula, thanks very much. And once again, I mean, in the maternity space, we do appreciate the support that VMI have given us. And, you know, I think it's not only the families and the mothers who suffer when things go wrong, but it's our staff as well. I mean, there's nothing worse than being somebody who gets a statement of claim because something's gone wrong. And if you've ever seen a statement of claim, it really goes out to try and make out you're the worst person on the planet. It can be very confronting. So it actually works both ways. And the other thing is, in fact, Ursula, I think, is it 20% of every payment we get for a birth goes to paying you for indemnity? Is it about that? It's a huge amount.
I think so. I'm not sure
the
actual number.
20% of every bundle of money you get for each delivery goes to, well, VMIA, well, not quite you, but goes to support that. So just think all that money we could have. And just if you've got an idea, one thing that I really would like to suggest you do, and I'm sure some other people might have some ideas, one of the things that I think most hospitals don't do well because we don't have the resources, you say a misdiagnosis. Well, who knows the diagnosis has been missed? The people involved with it know, but trying to get that discussed so you have that osmotic effect of learning in the hospitals, it takes time, and that's something we tend not to do. You know, we can look through our growth-restricted babies and our low APGARs, but once again, it takes a lot of time and trying to get the information back to people, a bit like Frankston, which is a fantastic project. We're going to induce everybody whose baby's over 4 kilos. Well, hello. Ultrasound's not a good way to do that. I think that's a fantastic little project. So they're the way I think that you actually have a great effect on staff learning, those sort of just embedded in your service.
Yeah, no, I agree. I mean, with the misdiagnosis program, it's fairly new in its infancy. It's not like, I suppose, in maternity where you might have a range of products out there like dashboards or the PSANS guidelines around M&M committees or, PROMPT or MSEPT or FSEPs. It's a little bit grayer. So at the moment, we're actually going to be looking at doing a bit of research, looking at what there is out there. And we've already had a group together to look at what are the things that are out there that we can support health services to implement to actually bring down misdiagnosis, because I do think it's not just in one area, it's not just in emergency department. I think it's also throughout the whole of healthcare. Yeah.
And because it doesn't matter what we do, education is a great way to provide better care.
Yeah.
So thank you very much.
Thank you.